Hi, everybody. I'm Aileen Comerton. I'm a family doctor, and I've had a comprehensive family practice for most of my career, but now I'm working at the Perley Health. And thank you for taking the time to come. And being in long-term care, I want to thank you all for the work you do in long-term care and any of my Perley colleagues who are attending. And like the saying goes, it takes a village to raise a child, and it takes multiple team members 24/7 to take care of their residents in long-term care. And it's very complex. In family practice, we have the advantage we build up relationships and trust over years with a patient and their family, and often even multiple generations. And we see them for preventive care, minor health issues, establishing their trust. And then as they build up medical problems, physical and mental, we learn their strengths, their weaknesses, support systems, resilience, or lack of it. In long-term care, we meet the resident at their most frail and most vulnerable stage in life, coming to live in an institution that was definitely not on their bucket list after a series of life losses. We don't know them, we don't know their families, and long-term care doesn't have the best reputation, especially since COVID. Many are cognitively impaired. In fact, they quote numbers 70 to 80%. So we're often dealing with their family or substitute decision makers, caregivers, and families who are often close to burnout or burnt out by the time the resident comes. They feel guilty about placing them. Many are old themselves with their own complex needs. All to say, it's a monumental task to quickly build their trust and reduce their fears about life in long-term care. And before any of us get to the essential conversations, I would suggest that it's super important to spend time early after their admission to get them know them as a person, what gives them meaning about their lives, to build that trust so that we have some trust when we try to approach challenging conversations. And usually this is at the initial care conference 4 to 8 weeks after admission. We'd hope that they would have had done a lot of advanced care planning and have good knowledge of why they need the 24-hour care. But often with cognition problems, they're less able to appreciate their needs. And without a lot of the detailed information, they and their families often have fairly unrealistic expectations, which makes it difficult. So hopefully this evening, I'll give you a few tips on how to have some of those conversations. There's no one right way. They are difficult, and people are often nervous, apprehensive, fearful about bringing up these subjects. And if you don't have experience, it's often good to sit in on people who have experience or bring somebody experienced with you the first few times. And everybody makes mistakes, and we learn from them, and you find what works for you. There's no one right way. Now to move my, okay. So this is just some of the resources I used were from Area Labs, Hospice Palliative Care Ontario, and experienced palliative care physicians, Dr. Nadia Incardona, Dr. Jeff Myers, and Dr. Leah Steinberg. So the goal this evening is to give you an approach and some suggestions how to have the essential and sometimes difficult patient conversations. It can be useful in situations of many chronic non-curable diseases, breaking bad news with cancer and palliative patients and many other situations. And since pretty much everybody who comes to long-term care has life-limiting illnesses and is palliative, maybe not right near end of life, but the approach is palliative. So you want to have a safe space. Be mindful of what you say and your words. Expect some disagreement. And often it's the families who may have disagreement with you and different ideas if their loved one is cognitively impaired, or the resident if they're cognitively intact. And then you need to do a lot of listening and learn from each other, and often learning from the resident as well. So ways to approach, and this can be useful in all sorts of scenarios in life. Set up the conversation. In terms of health, you want to assess the patient's understanding of their health issues, their preferences, their goals. You want to share prognosis, and I'll talk about how you can do that with some hope. Exploring the key topics, and it likely will take many, 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 many visits. And it's often worth giving a lot of time early on, and then the following visits may not take so long. So for setting up the conversation, it's good to ask permission. Example, I'd like to talk to you about your health, your illness, find out what's important to you, provide the care you want, but avoid care that provides more harm than good. Are you okay with that? And again, that might be something you might do ahead of the care conference so that they have some idea when you start talking about these issues at the care conference. Sorry. So it would be good to be in a private, quiet space so that the patient feels safe. And can you arrange for no interruptions and not to be rushed at the time you're going to have this conversation? Is it the right time for the patient? Like, is it a time that they're normally tired, nap? Have they had their pain medications if they're somebody who's in pain, so that they're not in pain when you're trying to have this discussion? Do they want to have somebody with them for the conversation to support them or to take notes, to make sure, especially if they have any cognitive issues? And can you sit down and be at their level rather than standing up and looking down at them? So again, with the setting up the conversation, you want to do a lot of listening and accept without judging. Silences often allow you both time just to think and for them to process, slows everything down. And really the only judgment that for all of us in our work should be that we judge ourselves privileged to be given their confidence. So assessing, understanding goals and preferences, again, a lot of listening. So you ask questions and you listen. Assess their understanding of their illness and the prognosis, and assess their acceptance of the information being given. I've had one or two situations at a care conference when we started to try to have a discussion. The resident and the caregiver left the room. They weren't ready. They weren't able to hear anything. It was not the right time for them. So if they don't appear that this is a good time, then you postpone it. So assessing their illness understanding, you ask, what have you been told already about your illness, the cause of your pain, the cause of your symptoms? And again, always asking, did they like to have somebody with them? and how do they like to receive any medical information. Some people say, I want it written down. I want to see it. I want to review it after. And that helps me process it, especially, if they're very stressed by it. And then reflection. So if I understand you correctly, your main concern is whatever. The oncologist told you that the cancer has spread. The heart failure can be managed, but not cured. And it's important to sort of check this out with them. For an example, I had a patient who had advanced heart failure going to the heart failure clinic. I spoke to them at the heart failure clinic. I said, this resident doesn't appear to understand the chronicity and where he's at. And so they arranged for the nurse practitioner and the social worker to meet with him. He came back and he handed me advanced care planning palliative package, thinking it was for me. So, you need to clarify that they understand the message, because often they don't, or they block it out. Again, help me understand what happened with your visit at the cancer clinic. Help me what happened at the dialysis unit. Help me understand what happened at your last visit at the respirologist. And then maybe you could get them, how would you explain to your family what we've talked about today? How can you tell me, can I help you in how you're going to explain? And how would you describe the treatment options to your family? Is there a way I can help you prepare to have that discussion with your family? And what have you understood from Dr. B at the dialysis unit or from our discussion today? And again, it'll give you a sense of where they're at in terms of any understanding or their readiness to understand. So lots of listening and silence. Silence is okay. You can have just silence. So for sharing the prognosis, it's good to get familiar with the wish, worry, wonder, hope approach. And again, allowing for silences and explore emotions. Pay attention to the patient's feelings, their body language and emotions, and acknowledge them. Is this discussion, what we're talking about, making you very sad, angry, scared, anxious, or whatever you're thinking is going on? And then listen and allow for silence to give them time to try to explain how this information is registering. What amazes me is with admissions, sometimes we discuss the diagnosis and they're saying like, nobody ever explained this. I didn't know I had so many different organs having problems. Like maybe it had been told, but the message wasn't received, or they weren't ready at the time. So we say somebody has chronic pain. So an idea would be, I wish that you did not have chronic pain, for example, back pain. But you're not alone. Statistics show that 80% of Canadians have back pain at some point in their lives, and many may have chronic pain. I wish that you didn't have cancer. I wish that you didn't have Parkinson's. I wish that you didn't have ALS, or whatever it is that are all the issues. You don't have to name them all since they often have a lot. So then you can reassure them, say for somebody with pain, there can be times that it may be worse with flare-ups. I hope that you will learn to live well and long in spite of your pain, and learn some ways to prevent flares. And that would be an example with back pain. And then with maybe some of the other illnesses or cancer, you may have good and bad days during this journey, but the team will be with you to support you and manage your symptoms and concerns. And again, there are many ways to improve your quality of life and function, reduce, but maybe not eliminate totally the pain. And we can help you, assess these resources and other ways to manage. Our focus will be for you to have the best quality of life during the course of your illness. So what gives you meaning, how you can have the best quality of life given your health issues. Hope. So we say somebody has back pain and you've done an assessment. The good news is your physical exam and all the testing have ruled out any serious illness, cancer, broken bones, any serious bone disease or other illness. And again, for hope for some of the life-limiting, the good news is your symptoms are well controlled and that the medication is working without significant side effects. So you put a positive spin that we're having the symptoms controlled. So I worry, the wish, the worry, and hope. I worry that the current approach is not really helping and maybe causing some harm. So this may be a situation where people are wanting all sorts of aggressive workups that aren't going to make any difference, wanting to keep going to emergency repeatedly, and you're trying to have them have a more conservative approach. And again, allow for questions, emotional response, and silence, because, you know, they've watched TV shows where everything is fixed in a half an hour. And, you know, in the long-term care, I'm not the best doctor, but I'm not a magician. So again, depending on, you know, the situation, you would ask, is it okay to review your medication? And you would go over the medication pros and cons. This might be with the resident or their power of attorney. And again, if they came in on medication that wasn't the best choice, like an NSAID, for non-end-of-life situations, you might discuss the risk of GI bleeding, blood pressure, kidneys, cardiovascular, and that while it might have been a good medication when they were 50, it's not the best choice now. And again, get them to buy in that you want what's safe for them. And again, when we're at the very end of life, you have the opposite end of people who maybe don't want to take medication. They're afraid of taking, they've heard morphine will kill you or it's addictive. You reassure them that the end of life with a palliative approach, there's no worry about addiction to the medication, to reassure them. And again, in the non-end of life, and you're talking about somebody who comes in with a bag full of medications, 20 different medications. You worry about the number of meds and the drug interactions. And again, at whatever time it may be appropriate to look at deprescribing, how you can sell that as in their best interest for safety, that there's less benefit than the risk they're taking. And again, worrying about the side effects, the dose of the opioid in the non-end of life, sedation, constipation, dry mouth, slower urination, fall risk, delirium, and even death. And since all of them have constipation in long-term care, and many of the men slow urination, and they're often falling, you know, this is significant in terms of concern. And then for the ones who are, you know, needing the meds and not taking them, you're worrying that they're holding off on taking the pain meds or PRN meds. Again, allowing them time to ask questions. So I wonder if you're open to some improvement in your medication regime. I have consulted with the pharmacist for guidance as to the best regime. And then you would bring up, you know, that at 95, the benefit of statin or whatever you're wanting to approach when they come in on benzos, or other drugs that may not be appropriate at the age or whatever. And then exploring what are their biggest fears about your health and how it will affect your future. And what's the most important goal you have if you have to accept that your cancer, heart failure, back pain is not curable. And again, it may be if you knew what their past life was like, what their interests were. You can have in motivational interviewing a sense of, well, can they attend the concerts if they're really into music? If they were gardeners, can they go out to the gardens or nature or whatever? That you get a sense of what will give them meaning and pleasure. And then exploring their past strengths. You know, what helped you through tough times now and in the past? And sometimes it was not the healthiest. And that may not be something you're going to promote if they drank alcohol to deal with issues. Hopefully they had some healthy supports like their family or distractions, their hobbies. And the problem for some of them is that they may not be able to use those same resources now because of their disabilities or limitations or whatever. So you're looking through if you can find something of their past that was a healthy coping or support, spiritual, religion, whatever, that might still be available to them in their current state. Then knowing who are their biggest supports, and that varies for everybody. Sometimes there's not the best family dynamics, or some members of the family are a support, others are a cause of stress. So you can look at trying to find out what's a support rather than a stress. And again, asking them, have they talked to their support systems, their family, about what's important to them? The idea being that they would have done this in the past, they would have done this before they lose any cognition, and then that the family, who are their substitute decision makers, know exactly what's important to them, can speak for them when they're not able to speak for themselves, and follow their wishes and respect their wishes, even if they're different to what that member would do themselves. And the problem often is that this has not happened, since 50% of Canadians have not discussed advanced care planning. And those who do, sometimes their power of attorney is their spouse, who also may be very elderly, also may be very frail, may at this time also be cognitively impaired. And it can be a disaster that things were not sorted out ahead of these crises. So again, hope. I hope that using all the tools available to manage your pain, nausea, shortness of breath, or whatever, that we will have improved function and a better quality of life and achieve the goal of whatever they said their goal might be. And sometimes, you know, their lifespan is not looking very long, but it might be they wanted to be around for their granddaughter's wedding or whatever, if it looked like that was even an option. So there's a lot of reframing and creating new expectations, which is hard for everybody because they've had, you know, a loss of independence, a loss of physical or mental stress, a loss of their ability maybe to do a lot of their interests. So life has brought them a series of losses. So how can they reframe and create some new expectations that will give their life meaning? And that might be just short visits with their grandchildren. Maybe it's audio books, maybe it's going to the concerts, whatever. and then reassuring them that I want you to know that even though we do not have a cure for your illness or pain, there are many things that can be done to reduce your symptoms and improve your quality of life. So again, let's review all the options, non-drug and drug options, and that's usually for most things. We're looking at non-drug and drug. So in somebody who's able, are they able to participate in self-management programs, or can their powers of attorney play a role? What exercise can they do with the support of the physio? And maybe meditation, mindfulness, even though the cognitively impaired are not able to do that. Physiotherapy, assisted devices, if they're indicated, physio and OT may help. Recreational activities are super important. Spiritual for those folks where that's a support for them. And then psychological, emotional, family support. These would be more for someone with chronic pain rather than end-of-life cancer. But again, end of life, they can still be having maybe music set up in their room. The family can set up maybe slideshows of past nice activities. There still may be things that can be done even at end of life. And again, the staff are often replacing the family when people don't have a lot of family around, and they're the family substitutes giving emotional and social support. So again, for the people who are not at end of life, it would be that you're looking at medication, trying to manage side effects, and how giving education about the medication and drug interactions so they're aware. And it's a process, and it takes a lot of time and many visits. And that varies from one resident to the next. Just like in life, you have people you meet who have very high needs and others who are pretty independent. And again, the residents, some people who have a lot of complex issues are coping fairly well, and many others are not. So you need to tailor it to each patient and also their illness understanding and what they are ready to hear. And sometimes they're not ready to ever hear. And denial is their way to cope, and they don't want to know. And, you know, they live their life like that, and they don't want to plan. They don't want to know. Hopefully somebody of their family substitute decision maker wants to be part of it. And where are they in their readiness stages for change? So, you know, they come in and you get to the point of planning care, and they're saying, oh, I want everything. I want CPR. I want to go to the hospital if there's any change in my condition. And you somehow have to, you know, explain about what might happen with resuscitation, if it was successful, what they might be like afterwards. Does that tie in with how they see themselves? Do they really want that? And again, going to the hospital and the reality of going to the hospital, their time in emergency, if their loved one is cognitively impaired, dealing with the chaos, stimulation, stress, and emergency, and in the hospital, all that is like in a hospital for anybody, but if you're very frail, elderly, cognitively impaired, and is it worth that for them, and explaining that to them. So what's the outcome going to be? Is it going to be any better? And what they have to put up with for what they think is, they might think it's fixable, but it's not fixable usually, and trying to explain that. And again, are there language barriers? Do they need to have an interpreter? Are there any culture issues that may be significant that you need to learn about, whether that's along the course of how you care for them or at the end of life? And to find out about this ahead of the crisis, so you know if you can accommodate it or not, and if not, so that you've talked about it before. So empathy, support, and listening is always important. We can't change a lot of their situations. We can't fix them, but we can support them and listen to them. And it's hard to get buy-in sometimes, so it takes time, and you just may need to give them that time. So other phrases, it must be difficult for you to have to reframe your hopes and expectations. And then give silence, pause. Maybe they'll answer, maybe they won't answer. But, you know, all of us are not upset by somebody saying it must be difficult. And then do you have hopes and dreams that have been threatened by where you find yourself now with your pain or whatever limitations or symptoms? It must be difficult that you have to live in long-term care. It must be difficult that somebody else has to take care of your finances. It must be difficult, whatever. And then closing the conversation. Again, the reflection. I heard you say, whatever, time with my family is really important to you. Keeping that in mind. Or I heard you say that walking is really important, keeping that in mind. I really recommend you put your focus on the time with the physio, that the walker, whatever. How does this plan seem to you? If it seems good to me, it doesn't matter if it doesn't seem good to them. The team and myself will do whatever we can to support you in your health journey. Again, it must be difficult, it's never going to get you in trouble. Let's plan the next step together. How are you feeling? What resources do you need? Again, questions about their understanding. What do your symptoms mean to you? What concerns do you have about what is happening and what the future holds? Avoid lecturing, blocking, shutting them down, reassurance of a cure or a quick fix. So again, summarizing, you set up the conversation and get permission, assess understanding and preferences, share the prognosis if you can, and they want to hear it, share key topics, again, about what's important for them, close the conversation, and then you want to document the conversation and communicate with the team what you've discussed. And then everybody's on the same page and everybody has an understanding of what information has already been given. And if another team member is asked something and you're not sure, you can just say, I'm not sure. I'll have to check that out with the other members of the team. I wasn't a part of that discussion or whatever. That's a very important question. I'll check that out for you and get back to you, or have the physio talk to you about it, or the doctor, or whoever. You can always say you don't know. That's okay. So we're all learning forever. Keep practicing. And, different things work with different situations. We learn from each other and from life, and some of these things you can use outside work. And these were some of the resources that I found useful, and again, may give you some ideas as to ways to approach these conversations. And, you think of it often like trying to cross a river with stones. And for, a tiny river, maybe you can get to the other side easily. But for some of these complex situations, it takes many steps, and that's okay. And because it's challenging, it's hard, and the resident, even if they want to receive the information, needs time to process, time to accept, time to grieve, because it's really hard. And you're playing a big role in helping them at a time of their lives when they're most vulnerable. So thank you, and any questions I can answer or try to answer, I'm happy to.
So there is a question in the chat. So May asks how to start a conversation to a POA that has been in denial of the decline of the condition, such as advanced dementia, and if they have false beliefs of having an infection or the side effects of the medications are the cause of it.
So if I understand correctly, you're saying, how do you deal with somebody who's in denial that they themselves have dementia, or the family is in denial that they have dementia?
The question's posed as if the POA is in denial of the progression of the dementia.
Well, again, I think you have to listen, a lot of listening, and probably something like it's hard to see your mom weaker than she used to be. And you might actually have them reflect on what she was like, and maybe tell you what she was like in 1 year ago, 2 years ago, and then 6 months ago. And maybe in telling the story, they might come to see that there has been a decline. And again, if they're thinking the medication has played a role, and sometimes it might have affected cognition. So you can explore which medication they were concerned about and look at the timing and say, you also want the safest medication, and hear them out, and review the indication for the medication and the dosing of the medication. And that may be challenging because they may never, I hear all the time, my mom has a bit of dementia. And, the cognition testing is advanced dementia. And so again, it's often having them come to tell the story, and by describing what's happened over the last number of years or months, they can see the decline. And again, you may never convince them. You can do things like that dementia is a different disease and presents in different ways to people. And like any condition, there can be mild, moderate, and severe. There can be good and bad days. There are very good resources. You can give them resources through the Dementia Society. I use resources from McGill University. There's a caregiving handbook. I have resources from BC, again, if they want to and are ready to learn about it. And I don't say that, your mom or your dad definitely is, whatever. I'll say that there is progression, and then depending on what comes up, I'll bring up whatever symptoms, signs we're seeing and have them maybe review the information and come back and we can talk more again. But you just listening to them, they're obviously struggling. It's hard. It's very hard. It's very difficult. Must be difficult. Yeah, I see the point there that families are in some degree of denial to cope. They are. And again, if that works for them and it's not interfering with the care of the relative, for example, where it might become an issue if they're saying, well, I want them to go for heart surgery, or I want them to be investigated for colon cancer, or I want this or that, that's really not their best interest, then it may be a different conversation than somebody who's just in denial, but it's not causing anybody harm.
Do you have some tips as to how to navigate if there are folks who were hoping for certain investigations like the examples that you provided?
Well, if for say somebody who had an 87-year-old, and they mostly don't just have dementia, so they may have cardiac, renal, diabetes, high blood pressure, maybe COPD, maybe Parkinson's, like a whole bundle of things. And you might say, well, if you're 40 and you're bleeding from your bowel, of course, the recommended would be this, that. And so what's involved in the initial investigation would be drinking 2 liters of a laxative. We have trouble getting your dad to drink 2 glasses of water. So that would be that maybe you have to sit with him and have him drink the 2 liters of water or of the laxative. And then he's going to have like diarrhea, emptying his bowels for hours and being on the toilet. And, that's hard for him being on the toilet. And then you have to take him out to the hospital. He's going to have this big tube put up his bum. And then even if he has this test and they find something, then what? What are we going to do about it? Do you want to have him consider surgery? And the risks of surgery are death, blood clots, picking up superbugs in the hospital, delirium, or radiation, chemotherapy. And you would just discuss these are all risks. And that if you're young and fairly healthy, you might be willing to go through hell in the work of investigations and all the treatments with chemo or radiation, because the outcome will be supposedly good if it was a treatable cancer. But for somebody who's already pretty frail, is that going to be really doable for them when you're telling me he struggled going to the appointment with the dentist? And that took days of planning, and he didn't settle down afterwards, and this will be multiple trips in and out all the time, and you just explain the process. And then is that what you think she'd want? Is it worth it? And it's going to be really hard. And again, I think in a lot of these cases, if there is a challenging family who wants everything, it's important that the whole team are on board with the same message. So they're not splitting up people and, saying, Carl, the night nurse, told me that was a great idea. And then you're having to dispel this, or it was a replacement staff member who didn't know the dynamics and then got caught into something they weren't really aware of, the problems that the team were having. So that's why I say it's okay to say you don't know, rather than say something and then you don't realize that that's just lighting a fire that we've already spent a lot of time putting out. It's fine to say you don't know, and that, you need to check with the team, and that, you're not regularly on the unit, and you don't know the full story. You better check it out. I wouldn't want to give you any false information. You have lots of complex needs. I need to check those out.
Yeah.
And again, it's like I see a comment here that, make the family, rather than running them around for all these tests, just to make the most of the time they have and not waste it on all these visits to specialists, the hospital, tests that totally exhaust their loved one. And they're not really having any quality time with them, rather than just have some quality time. And, that speaks to, ahead of all this, maybe having the advanced care planning, what's important, so you can feed that back. Your dad told me, he just does not want to go to emergency again. And that was so difficult the last time. The resident, the patient in the next bed climbed over him in the middle of the night. And, he can't deal with that. So you can give, if you've had some of these discussions earlier. So I think that everybody's on the same page is really important. I'm just wanting to read here. Louis, how important is communication between all members of the care staff to avoid inconsistent in messaging, and what strategy found successful? I think if you get any signals that the person's understanding of whatever their situation is doesn't tie in with the diagnosis, just check with the other team members, because you're probably right. And, if it's OT or if it's physio, and, I think that's Louis, and the person he's probably thinking about is my resident who, thinks he's going to walk, and he's after a stroke, and, he won't walk. So that we're all on the same page, and that you just check with the other team members. And, you may get a different message, so it's good. We all hear. There's all sorts of stories, and we can share them, and it can help us. Was there any other question I didn't answer or address?
Yeah, there was one that just came up here. They said, just wondering if you have a template to guide this discussion that you use.
I've been doing it a while, so I have my own way, and I sort of read it. But what we do at the Perley, for those people who are not at the Perley, at the care conference, we start the care conference with, we're all new here with knowing you. You know the resident best, the family know the resident best. We're wanting to know what gives joy and meaning to this person. Tell us a little bit about, their interests, their hobbies, what's important for them. And you tell us, guide us how we can best care for your loved one. And again, you'll get a sense from that if they understand and if they have realistic expectations or no. But also it tells you, well, this person really likes music or art or whatever, so you can have recreation, because that's huge. And then I go over the diagnosis. And a lot of the time, it's a big cocktail, and have a sense of, have they, are they going anymore for appointments? So, and is it worth going for appointments? So are they going to the cardiologist, but, this is the end of the road, and is it worth it to go out? And again, the kidney doctor, sometimes they have a great relationship and they want to keep it, and it's worth it for them. I'm new. and everybody is new. So, you know, they don't trust me. They don't know who I am. And so they may have had this doctor for a long, long time, and I'm not going to tell them not to go. I may touch base with the doctor and say, you know, really, do you want to wean them off because it's taken a lot out of them or whatever? Um, and then we go on to medication. And if there's inappropriate medication, we might have to try to address that. And that would be something, again, varies from family or resident, and which medication, how dangerous it is, and how we can approach it and get them to buy in. We'll talk about their frailty, explain a little bit about disease trajectory, the future uncertainty. They could die at any minute, could die this afternoon. A lot of them, I look after the vets, so they're very old. So that every day is a good day, every moment is a good moment. If you have things to resolve, try to resolve them. Then we talk about fall risk. So we you know, we wish they won't fall. We worry if they fall, they'll be worse. And we wonder, you know, will they use their walker so they won't fall? And we review immunization, and then we might have the whole issue of the anti-vaxxers that we have to navigate. Not many, but some. And then we'll maybe review any investigations, and we'll make a plan. And we'll say, are you okay with that? We'll summarize. And depending on, you know, how frail they look, sometimes, you know, they look like they're not going to be around for very long. So we may have to, we'll discuss as well, would anything be important at end of life? Have they got funeral arrangements? And, you know, we're always dealing with, well, we hope for the best, but we're planning for the rest. And we're trying to have discussion now so that it's not happening in a crisis. And that if we hope you don't have to deal with these crises, but I use the example, I say if it's the doctor on call, phoned in the middle of the night, they don't know you, so it would be hard for them to be having this conversation. Whereas if you've already thought about it, the nurse can tell the doctor on call, this is what this. And I just say, for me, I say, if it's me on call, I just say, what's the plan? If the plan is send them out. I say, you call, and I try to get back to sleep. The plan is not send them out. I have to wake up and sort it out. So I hope there's some pre-planning done. You know, I joke around a bit. Depends on the situation. So that, you know, I say, like, be prepared like the Girl Guides. You know, we hope for the best, we're planning for the rest. And maybe we won't need to use these plans, but we have them ready. And then summarize everything. And that would be the ideal. That would go smoothly like that. And it may be that it's an hour, maybe longer, and it may need repeated visits. You know, sometimes it takes another year before we'll have made any progress. Any other sort of questions that I didn't see?
No, I don't see any so far. If anyone has any though, feel free to write them in the chat. We can give it another moment here.
And this is just a very brief, you know, some ideas, and people have their own personalities and their own ways of approaching some of these things. But I see a new one. Great presentation. Thank you. Thank you. Yeah, you find your own way. And again, you know, if you mess up, you just look at how you might have done differently. Because sometimes it's very challenging depending on the family. And ask somebody else, you know, ask other people, what would you do in this situation? How would you have approached it? And then, you know, you'll learn from that. And next time you'll have a different way to navigate it. There's no one right way.
Well, all the comments now are people just thanking you for giving such a helpful and insightful presentation.
Yeah, I hope it gives you some tips and tricks. And as I say, each family is different and each patient. But, you know, if you just remember as well that um, they've lost pretty well everything. And, you know, they've lost their independence, they've lost their careers, they've lost many of their friends. Sometimes some of their kids are already dead, and they have many complex health problems. They've lost their ability to do a lot of their fun activities. They're nearly dependent, a lot of them, for everything. So if you can be there for them in a small way, it's great. And I hope it helps you. And fill out the survey.
I see Fred says those of us who care for these people are so important and make a huge difference.
Yeah, we do. You know, it's very important. And I have a sad story, you know, to tell about how important it could be. I was having, it's sad and funny. Was having this conversation. You know, he was a joker. He was from Newfoundland, and he, you know, we wanted to know what might be important at the end of life. And he said, "Well, I want you to arrange for me to go upstairs because I'm going to be cremated, so I'll already be fried. I don't want to go to hell." And I said, "Well, my sort of purpose is here, but let's hope we all go upstairs." And he said, "I'm not finished. I want you to come with me." And I said, "Oh, that's very nice, but I don't know if I'll be going at the same time." He said, "You got to come at the same time." And I said, "Why do you say that?" And he said, "Because I don't know what you look like. I've never seen you without a mask." This was during the pandemic. So that's how sad it is for them in terms of how the pandemic was. Everybody was masked and they didn't know what anybody looked like. And a lot of them have vision problems, hearing problems, cognition problems. So anything you can do is good. So thanks, everybody.
Oh, thank you so much for this wonderful talk, and thank you everyone for joining us tonight. As has already been hinted, the link to the survey is posted in the chat, and I'm sure it'll be sent out along with a copy of the recording. And thank you again so much, Dr. Comerton, for joining us tonight.